Welcome everyone. Thank you for joining us today. We will get started in just a minute. For those of you on the call already, your lines have been muted to reduce background noise. Thank you. Good afternoon, everyone, and thank you for joining us for the California Quality Collaborative's Increased Depression Screening public webinar. We're delighted that you're all here to join us today. As a reminder, this session is being recorded. We will be posting the recording and presentation slides as well as any resources mentioned on our website after the webinar is complete. Before we get started, I'd like to pause for a moment on a few quick Zoom tips. We will be having a number of polls during today's session. To submit your answer, make sure you click the blue submit button to complete your vote. You may also use the toolbar at the bottom of your screen to join and mute audio, stop and start your video, and view who else is in the virtual room. There's a chat button if you would like to ask questions and insert comments. We are now sharing a PDF of the slide deck if you would like to follow along. Just simply click the download button in the chat window to save the PDF to your computer. If you have any technical issues during today's session, please direct your messages to me, Rachel Lin, and I will do my best to assist you. And with that, I'm going to hand it over to Christina Modi, who will get us started today.
Thank you so much, Erica. As we're all getting settled, let's do a quick warm-up poll to see where you are all coming from. So please let us know where you are regionally and from what type of organization by answering this poll. As you're completing the poll, I'm going to go ahead and introduce myself. My name is Christina Modi, and I'm Senior Manager of Care Redesign at the California Quality Collaborative. While we are California-based, we have many national partners, plus interest in behavioral health integration is important to the healthcare delivery system, no matter where you are. So as you are completing, let's give it a few more seconds. And let's go ahead and share the results. So I'm really delighted to see that in addition to our California presence, we have a couple other of states represented. So thank you for tuning in from wherever you are. I'm also happy to see that not only do we have provider and practices, but IPs, medical groups, and some health plans, because behavioral health integration represents a real opportunity for collaboration. So really pleased that you were able to tune in today. On the next slide, I'm going to talk a little bit about who we are. CQC is a program of the Purchaser Business Group on Health, which was until recently known as the Pacific Business Group on Health. Our role is to support improved quality across the healthcare delivery system in California, which we do through improvement collaboratives, stakeholder convenings, and capacity building events like this one. Behavioral health integration is one of our specific aims. And Eric is going to put a link in the chat to our website where you will find today's webinar and other related materials. On to our speakers. I am so thrilled and excited and grateful at our amazing roster of speakers today. We are bringing you not only the clinical, but the measurement and technical perspectives of how to do depression screening well and the lessons that they learned along the way. I will introduce our presenters in greater detail right before they speak, but know that you will hear today from my colleagues at the Purchaser Business Group on Health, UCLA Health, and Montefiore Medical Center. So Right now, let's open up and do a little sharing. You've joined today's webinar because you're interested in learning how to increase depression screening. So please enter in the chat. How has the pandemic changed the way that your organization approaches depression screening? Perhaps you were planning on expanding screening, but haven't been able to because of other operational constraints. Maybe you've been doing informal screening and you're looking to expand it. We'd love to hear some of those, your experiences in the chat. As the answers come in, I'm going to briefly cover our agenda for today. We're going to cover the importance of depression screening clinically, as well as from a policy and payment perspective. And then we're going to hear some amazing examples from the organizations I mentioned who have taken a data-driven, patient-centered depression screening approach. Also know that we want you to come with your questions and experiences to share in the chat. We're going to take questions after our presenters share their content. Also, we're going to have an opportunity to reflect on something that you've taken away from today's webinar. So with that, let's see some of the, I didn't see anyone sharing their experience is in depression screening, but I hope that you might do so later in the webinar. With that, then I'm going to turn it over to my colleagues from PBGH, Rachel Brodie, Senior Director, and Valerie Kong, Senior Manager of the Measurement and Accountability Team. Rachel?
Thank you, Christina. I thought I'd start by providing some background about why PBGH has made mental health a strategic priority. Our employer members recognize that mental health issues have a significant impact on their employees, their clinical outcomes, and also overall healthcare costs. As you probably know, depression affects millions of Americans. The most recent California Healthcare Foundation Kaiser survey found that 27% of California's residents have experienced a mental health condition in the past year. Nationally, annual prevalence is estimated to be up to 10%, and lifetime incidence varies between 10 and 20%. The cost of illness estimates range from $44 billion to $210 billion per year, and much of this is due to lost work productivity due to depression. Moreover, we know that diagnosis of depression impacts comorbid conditions and treatment adherence. And then, just to make things worse, the pandemic has really exacerbated mental health conditions, and it has had a disproportional impact on underserved communities. So with knowing all of that, we also know that depression is often underdiagnosed. Access, cost, and stigma are significant barriers to screening for mental health issues and also to getting treatment. However, there are some important emerging policy and payment initiatives that are intended to advance measurement of depression outcomes. The Integrated Healthcare Association, or IHA, and PBGH have partnered to develop a commercial ACO measure set that includes a suite of depression patient-reported outcome measures. Therefore, providers in California will be expected to report these measures to IHA. So one aim of today's call is to share how provider organizations are approaching depression screening and outcomes measurement. Depression prompts are also part of the CQC PBGH Advanced Primary Care Measure Set, which is being piloted by Covered California next year. And part of the Department of Healthcare Services' new CalAIM program is designed to address behavioral health access by implementing behavioral health payment reform. If we go to the next slide. This slide provides an overview of some of the activities that PBGH has undertaken over the past year. I mentioned that PBGH and IHA have partnered to engage health plans, provider organizations, and purchasers to endorse a common set of commercial ACO measures. We very much prioritize mental health measures, and particularly PROMs using the PHQ-9. IHA will be testing the depression PROMs this year, so these measures will be implemented at scale across the state. Understanding, though, that these measures require time, resources, and new workflows for many organizations, we have been convening leaders in the field to share their approaches to depression screening and measurement-based care in order to elicit and disseminate best practices more broadly. We've had in-depth discussions of PHQ-9 implementation strategies, with also a specific focus this past year on methods to adapt to virtual care environments. Another thing we are doing is developing a PHQ-9 implementation toolkit, which we expect to disseminate this year, hopefully midway through the year. So the presenters today from UCLA and Montefiore come from two health systems that have demonstrated successful approaches to depression screening and measurement-based care, but two very different approaches. So we thought it would be really helpful and inspiring to you all. I'll turn it over to Valerie for the next slide.
Great, thank you, Rachel. And so while we've talked about depression treatment and measure-based care during this introduction, today our presentation will mainly focus on screening for depression. As Rachel pointed out earlier, we know that screening rates for depression are low, and therefore depression is often underdiagnosed. And as you can see in this slide, screening is the first step in the continuum of measurement-based care, in which patients that screen positive for depression are referred for counseling and other treatment options. And then the provider follows up with monitoring patients based on their responses and or enrichment over time. Also on this slide, we've included some example questions that could be helpful for providers to consider during their workflow planning and how they're going to approach screening and follow-up. Our presenters today will talk about their approaches to screening. And with that, I will hand back to Christina to introduce our second poll.
Thank you, Rachel and Valerie. Yeah, I think what's important about just framing this conversation is when you all registered to attend, you shared a lot of great questions, some of which were about data sharing and just other components that we're not actually going to be able to talk about in the scope of today's webinar, but very important in doing this work. So now we're going to launch a poll to hear about, if you are an organization that does do screening, which patient populations that you are screening for. I also want to call out there's a screening glossary in the appendix that you might find useful after the webinar. While you complete this poll, I'm going to go ahead and introduce our next three speakers from UCLA Health. Dr. Jessica Jeffrey is a child and adolescent psychiatrist at the UCLA Semel Institute for Neuroscience and Human Behavior. She's the Associate Director of Ambulatory Services within the UCLA Department of Psychiatry and the Associate Director of the Population Behavioral Health and Child Adolescent Psychiatry at the Semel Institute. Dr. Jeffrey is also the lead psychiatrist at UCLA Behavioral Health Associates. Dr. Clara Lin is a primary care, internal medicine, and pediatrics physician at UCLA Health. She's also a physician informaticist with a special focus on population health and specifically behavioral health in the primary care population. Rachel Linonis serves as the Director of Digital Solutions for the Nathanson Family Resilience Center and the UCLA Division of Population Behavioral Health. She focuses on figuring out ways to leverage technologies to support population behavioral health efforts. So thank you so much for those that voted, and thank you to our speakers. Let's go ahead and share the results right now. So it looks like we have primary care general population as the top choice, followed pretty closely by adults, and care management, primary care enrolled in behavioral health tied with adolescents next. So interesting data. So I'm going to turn it over now to you, Jessica. Oh, I think you're on mute right now, Jessica.
Thank you. Step one is to unmute. Hello, everyone. It's so wonderful to be here today to talk with you about our screening efforts for depression at UCLA Health. Today, we will focus on our screening in the primary care population, but I just also wanted to provide a snapshot to let you know that we do screening for behavioral health conditions, depression, and a couple others, which we'll mention as well, in primary care, also within our integrated care program called Behavioral Health Associates and our Department of Psychiatry. And the screening looks a little different depending on the location in which the screening is done at UCLA. And again, today we're going to focus on the primary care population, of which we have 390,000 primary care patients at UCLA. So this has been a huge undertaking and something we've been working on for the past approximately 3 years. Between some of the data we have for you today, between January of 2019 up to this current month, March 2021, we've completed within our health system over 22,000. We call them BHC, which is called Behavioral Health Checkup Screenings. So as you can see, we've been really working very diligently at this. The reason we call them the BHC screenings, and actually if we could advance the slide, I'll explain a little bit more. Thank you. It's because we have a really, I think, a unique approach to our screening here. The initial screening is with a PHQ-2, and if that is positive, the patient is then gated into a longer set of questionnaires. So there's actually 4 different questionnaires. The PHQ-2 gates into a PHQ-9, or the Patient Health Questionnaire 9, which I know that you guys all know is for depression, but it also gates into a GAD-7 for anxiety, an audit C to assess for any substance misuse or alcohol misuse, and then a 1-item substance use screener. And if that's positive, it will screen into a DAS-10, which is for non-prescription substance use. So we really have, we start off with that depression screener, and really, I would say the core focus is on depression screening. But we also include these other screeners. So I think it's important to mention that. This slide actually speaks to our workflow pre-pandemic. And as you'll see, and as Dr. Lin will talk about in the next slide, during the pandemic, our workflow has changed, and we have found it to be difficult to actually do a screening as per our previous pre-pandemic workflow. If we could actually go back, I'm so sorry, I'm still on that slide. Yeah, perfect, thank you. So we actually, to give you just an overview, some of this hasn't changed, and we'll point out the areas which have developed during the pandemic, but we screen annually. If a patient has a positive PHQ-9, or that PHQ-9 is greater than or equal to the score of 5, we also give that PHQ-9 every 3 months. So it's a screening, and then also measurement-based care practices, right? Because we want to make sure patients are actually responding to our treatments, and we're really guiding those treatments to optimize the behavioral health outcomes, which we know, of course, impact overall health and ability to function in their daily lives, for instance, at work and at home. This screening does occur in the clinic. So in pre-pandemic times, the computer would prompt our medical assistants to give a PHQ-2 or a PHQ-9 if that screen was previously positive. So if they'd had that positive PHQ-9, remember, they're going to get that every 3 months. And then on the tablet, the patient will actually complete these the BHC questionnaires, which would be the PHQ-9, the GAD-7, the audit C, and that 1-item screener. All of these results are inputted into Care Connect. So essentially they take the screener on the tablet. At this point in pre-pandemic times, we were really focused on using a tablet-based, I should say it was a web-based platform that was integrated with our EHR and is still available in some of our other settings. At this point, we are moving more toward MyChart, but the workflow is still the same in the sense that the screeners are taken on a tablet, for instance, in this case, pre-pandemic, and then it goes straight into the EHR. So it's available for use within that visit by the physician. So the primary care doc can see that, what the score is. It's available in flow sheets and also available as an assessment note. One other thing I want to mention before I turn it over to Dr. Lin is that we also have best practice advisories, which have been really helpful. So for any patient that scores positive on PHQ-9 question 9, we want to make sure that we're really doing a thorough suicide risk assessment. So we have hard stops, the best practice advisory, and we've actually built in the CSSRS, or the Columbia Suicide Severity Rating Scale, to assist with that suicide risk assessment and to help our providers make decisions as to how to best treat that patient and do safety planning in that particular appointment. And now I'm going to turn it over to Dr. Lin, and she's going to talk about our workflow at this current state during the pandemic.
Okay, next slide, thank you. So the pandemic threw a big wrench in our workflow, as most of you know, both in terms of our day-to-day patient care, but also specifically in depression screening. At the beginning of the pandemic a whole year ago, we saw a pretty quick drop in the number of clinic visits because people were just so unsure about the virus. Annual physicals, routine follow-ups, those were all getting canceled and delayed. Patients are also much more hesitant to come in for some of their illnesses, including depression and mental health care. And so as a result, our overall depression screening and primary care dropped pretty quickly. But then also just as quickly as a health system, we ramped up our telemedicine visit functionality so that we can continue to provide care to our patient. And so depression screening had to adapt to this new way of seeing patients. You know, the pandemic really changed the landscape of patient care for us. And so on the slide here, you can see our pandemic era workflow for depression screening. Overall, the overarching directive is the same. The clinical need to screen patients annually at the minimum, and then also every 3 months if they had a previously positive PHQ-9, that remains the same. But we must now be able to screen patients remotely from home because a bunch of our patients are now doing remote visits with their doctor. Or if they're in clinic, we have to be able to do it in a COVID-safe manner. And, you know, thinking back, if you can recall back in March, we didn't know what COVID-19 really was, whether we all touched the same iPad or sharing the same computer keyboard, whether that's an hour apart or 10 minutes apart, what is the infection risks there? We really didn't know any of that. So our entire workflow in the clinic had to sort of adapt with the evidence, but also had to evolve pretty quickly over the year. And so what we are doing currently in the pandemic era is our workflow in primary care still starts with the back office staff rooming the patient in one way or the other. If the patient has a video visit, then the MA or the LVN will log on to the video visit ahead of the physician to obtain vital signs from home if they have any, their chief complaint, and also perform the verbal PHQ-2 if it is indicated for the patient. They're still prompted by the computer to do the PHQ-2 if the patient is due for it. In the clinic, the MA will do the same as usual, doing the verbal PHQ-2 while they room the patient. And either way, if the patient is screened positive on the PHQ-2, then the medical assistant will assign the patient our BHC questionnaire, the 4 questionnaire bundle, to the patient via MyChart. Now, the patient can then log on to MyChart on their own device through their app or their computer if they're at home. If the patient is in clinic, we encourage still to use their own device because we don't want them to be sharing computer screens or iPad tablets because that could act as a foci for infections. And so once the patient completes this on their device, they press submit and the physician can review the questionnaire response as per usual on the EHR as soon as they submit those questions. This workflow leverages our virtual rooming process and also allows the patient to complete the questionnaires from home. But of course, the biggest concern with something like that is for patients that are endorsing suicidality when they're not in the office. Our health system recognizes the importance of depression screening, even if the patient is seen from home. And so for that, we've instituted quite a few different safety net measures to capture these patients. The questions are currently only sent on the day of the appointment to minimize that risk. And then also before and after the questionnaire is given, the patient sees an advisory text that says their response is not being monitored in real time. If the patient additionally endorses suicidality on the 9th question, then there will be an additional guidance text that shows up that gives patient resources such as the suicide hotline for immediate help. And finally, for every patient that endorses suicidality, our computer system is tracking them and tracking that response. And if the provider has not yet taken any action in the computer system within 24 hours of the patient endorsing that question number 9 response, then the provider will receive an in-basket message to alert them of the patient's high-risk response and hopefully taking some action that way. Next slide, please. So here are some strengths and challenges for our process. In the new workflow, we have adapted to the new virtual visit process and made it possible for us to screen patients from home. We're also leveraging the existing workflow for medical assistants and also using MyChart, that is a familiar tool for both our patients and our providers. So we see that as our strength. We've also built a whole set of safety net measures to make sure that no patient endorsing suicidality from home would fall through the cracks. Our biggest challenges, though, is the nature of using MyChart in general. MyChart has a lot of limitations, especially when it comes to equal access for our most vulnerable populations, and even just those that are less tech savvy. So we're actively working on that as a health system. Additionally, our clinical staff has also given feedback that they feel like they're being pulled in multiple directions, having to room patients that are here in clinic, but then have to sign on to the computer to room patients virtually. But it's been a whole year of the pandemic, and people sort of have gotten used to it, and it's become a natural thing for all of our clinic staff by now. And then finally, we're still actively monitoring all of the PHQ-9 response, particularly the suicidality question across our health system. And especially those are coming from home. And so we feel that our safety measures right now are robust enough. We're tracking all of these on a weekly basis, and we're not seeing very many at all actually falling through the crack. And so during this experience, we're pretty confident in our process. And so we're now in the consideration of expanding this pre-visit questionnaire to more than just the same day of our clinic appointment. And then I'll let Rachel take over.
Hi, everyone. My name is Rachel. So I'm here to talk about the 96127, the billing code that you can use when billing for these assessments. So whether you're using MyChart or whatever survey tool you're using, and you adhere to certain requirements based on the billing, you have to provide the scoring of the assessment. You also have to provide some clinical your clinically expert language and guidance, et cetera. All of that has to be within the encounter and for you to get reimbursed for it. But this was something that was really interesting for us to track, because something that we noticed is that we do see larger reimbursements in primary care. And I purposely kept the dates January 2019 to December 2020, because sometimes there's back and forth with payers, and sometimes I just didn't want those numbers reflected because it may look lower. Sometimes it just takes a little bit longer. So that's why I said it may take a little bit longer to get it paid, because I don't know the details about that, but we have noticed sometimes it takes time. But regardless, we do see higher reimbursements in primary care than we do in the Department of Psychiatry and Behavioral Health Associates. Since January 2019, in that time period, we've dropped over 65,000 charges. So this isn't per assessment, it's per assessment. So in one setting, you could give a patient up to 4 assessments. That's what we've done. We give the PHQ-9, the GAD-7, and Audit C, and DATS-10. That's technically 4 assessments that you could bill for. And those, again, in primary care, we saw larger, I can't remember the exact amount, Jessica or Dr. Jeffrey or Dr. Lin, do you remember the exact amount? I'm sorry. It varies though.
The exact number of assessments?
Or the exact number, the reimbursement, I'm sorry.
Yeah, well, there's a charge, and then there's, sort of what ultimately is negotiated.
Mm-hmm.
And so, yeah, the charges, I mean, obviously they will vary by organization. Yeah. They're generally in the ballpark of $20-something, but then of course it's all insurance based. So it's whatever is actually the negotiated rate. And then the charge to collection ratio varies by the different settings, of course, as you mentioned, Rachel. And I think oftentimes what I've seen is that in behavioral health settings, so like in Department of Psychiatry or in BHA, those measures are considered bundled. So bundled into the care that you would provide as a part of a psychiatric visit, for instance. So I think that's also why we may see differences in those charge to collection ratios too. So yeah, so it's all kind of, it really varies.
Mm-hmm. Thank you. So this is something that we're going to continue to look at, and I think it would be great if we could do more of a deep dive analysis. These are more surface level, but this is something we've been tracking over the last couple of years as we've been doing these screenings. So, all right, and I'm done with my slide.
Well, thank you so much, Dr. Jeffrey, Dr. Lin, and Rachel. I think that they encapsulated a lot in their presentation about what they were doing, what changed, but also kind of they were responsive to some of the questions about coding that you all had as you registered for the webinar. And there's some great questions in the chat that we'll kind of revisit after we hear our Montefiore presenter. As I'd like to introduce her, please go ahead and complete this poll, which is how you administer your depression screening. As you complete that poll, I'm going to go ahead and introduce Dr. Michelle Blackmore. She is currently the project director for the Center for Medicaid and Medicare Innovations Cooperative Agreement for the Bronx Equity Integrated Care for Kids New York model, and the project director for behavioral health initiatives at the care management organization Montefiore Medical Center, which is in the Bronx. She works to develop child and adult integrated service delivery and sustainable state payment models to improve care quality and access to needed social services. She also has 13 years experience providing evidence-based psychotherapy and measurement-informed care. Dr. Blackmore?
Hi, everyone. Can you hear me okay? Just make sure this sounds good. Okay,
yes.
Great. Thank you, everyone, for joining today. I'm excited to say that it sounds like UCLA and Montefiore are pretty much aligned with a lot of the screening work that they do. So I'm going to try to cut short a little bit of our workflow and go over some of the areas where it differs a bit. All right, can you go to, or did you want to go over the poll results?
Yeah, I would say we had a mix. I think they flashed on the screen pretty rapidly, but I think we had a mix, and I think there's going to be a lot of interest in hearing your mobile app.
Great.
There we go. Yeah, a lot of hard copy in the office, a lot of followed by patient portal, and then tablet. So not as much app or mobile phone text, which means they're going to welcome your presentation notes.
Great. Okay, so Montefiore, just to tell you a little bit about us, Montefiore Health System, we're located in New York and provide specialty and primary care to, I think we have more than 100 ambulatory care locations right now, serve about 2 million people in the Bronx and Westchester County. So the patients that we serve, primarily minority population, definitely some of the most socioeconomically challenged, medically sick patients in the US. Most of our patients are living in poverty and often presenting with a lot of complex medical and mental health comorbidities. Similar to UCLA, we screen across settings and populations, behavioral health settings, case management, our work there, and at ambulatory care sites. So I'm going to speak a bit more to that. I think most of our audience might be interested in that piece. We do a 5-item screen. So it has the PHQ-2, GAD-2, and an alcohol question. And then if anybody scores positive, we go on to the corresponding tool. UCLA outlined all of those, so I won't go into that again. But it's nice to see there's some alignment there. We initially, probably about 6 years, it's been about 6 years since we changed the workflow, but prior to our change, we would have the screen pop up in the EMR when a nurse was rooming a patient. So the nurse would verbally administer the screen to the patient. And again, if there was any positive score, would give the full tool. We did find that just in terms of bandwidth time, oftentimes it was the PHQ-2 and the PHQ-9 that we're focused on, and sometimes the other screens would get left by the wayside a bit. And ultimately then the doctor would come in and talk over what the score results meant for the patient. What we noticed is we were getting about a 2 to 4% positive screen rate, especially for depression, which just was surprising for the patient population we're working with. So we actually started having the screens handed out paper copy in the waiting areas. So when somebody came in for their appointment, they were registered, they were given the 5-item screen by the front desk and would complete it, take it into the exam room, and then the doctor would go over the results. At that point, we started seeing, and pretty consistently since then, about a 12 to 14% positivity rate. I think I noticed somebody mentioned, had a question about that. Do you see a difference in terms of what you're seeing on the screens based on the way that you administer? We have found pretty consistently across patient groups and settings, much higher screening rate when the patient completes the scales themselves. Haven't done any kind of formal research on this, but anecdotally, patients often say that they feel a little bit more comfortable completing the screen. They have more time to think about it. They're not as pressured having somebody administer it to them. All right, next slide. So after we got the initial screening workflow in place, we really realized we needed to find an easier way to monitor patients more regularly. Our UCLA colleagues mentioned this idea of measurement-based care, measurement-informed care. So great, you have this baseline screen, you can identify somebody who's in need, but how do you monitor ongoing? And this is when we realized, obviously, limited time, providers, resources, we probably needed some type of technology solution that could really help us extend the work that we were doing, reach patients outside of the 4 walls of the office setting, especially because a lot of our patients found it hard to come into their appointments, a lot of different challenges there. So we started exploring different types of technology and ultimately found a smartphone app that was focused more on the behavioral health side and really would allow us to monitor symptoms, engage with patients much more in between visits. Next slide. Great. So here are some of the features of that app. And I want to call your attention first to on the right side, that little picture of the smartphone. That is what the app interface looks like on the patient side. So very easy, basically like a text message conversation. And if we want to send them any information, scales, educational materials, it's just a little link that pops up within that text message conversation. So the app that we use, just because most people are interested, I do not have a financial investment in this app, but it's called Clara Health. And it at the time was one of the few apps that had more of that behavioral health focus and not so much just the medical side. So we went with that. Now there's tons out there. But it really spanned a lot of different areas that we were interested in. It allowed us to do HIPAA compliant, secure chat messaging, video conferencing with patients, do those evidence-based scales, treatment goal reminders, appointment reminders, and send them out educational information, again, in between visits. One of the things I also want to note is there's a passive alert, data alert feature in the app. So if a patient, for instance, remains behaviorally inactive for a few days, the care team would get an alert saying, hey, you might want to check in on your patient because obviously behavioral inactivity could be an indication that symptoms are worsening. Or if you have exercise activity goals, it can help inform that work as well. So that was another, I think, unique feature of this smartphone app. Next slide. This is a question just that always comes up with technology. Okay, you're engaging patients in between session. What do you do when nobody's in the office to respond? And this is just an example of it's kind of hard to see, but in the background, you can see a little blurb that comes up for the patient. If they text off hours, it reminds them what our hours are, when somebody is likely to respond, and gives them an option to text or call crisis hotline if needed. Okay, next. Here is some of our data. So again, with I should take a step back and say in our primary care sites, we started probably about a decade ago to integrate behavioral health services. And that allowed somebody on the other end who was typically a patient educator, bachelor's level degree, not licensed, to monitor the app and dashboard. So the patient has the smartphone app, the provider or staff member on the other end has a dashboard where they can monitor all of the text message exchanges, responses back and forth between the provider and the patient. And this was offered every time a patient came into our setting. And if there was a behavioral health team on site, the care manager / patient educator would use this app to send scales to the patient, monitor how they were doing, and again, engage in all those features I mentioned. So about 3,000 patients enrolled, 70% engagement rate, so 70% of patients interested in using it actually signed on. The patient characteristics, this is pretty typical of what we see in our primary care sites. I will say those engaged in the app, a little bit lower, that 36 age range. I think our typical patient is more in the mid 40s, primarily female, and again, primarily ethnic breakdown of patients. We use this app, I do want to note, in primary care settings, specialty behavioral health clinics targeting patients with severe mental illness who really seem to enjoy using the app, and our health home care management programs. Next. All right, this is a breakdown of our engagement data, which I always get excited by. You see the bar graph that highlights the different app features. The gray bar on there shows what type of interactions our care manager or therapists were using on the app. So if they were sending out scales, chat, text messaging back and forth with the patients. And this really depended on whatever the workflow was in the clinics. You'll see, for instance, some of our clinics were not sending educational materials. That wasn't part of their workflow. Maybe not appointment reminders, that was done automatically through a phone line. But what's really interesting here, I think, is that blue bar, that across the board, patients were actually responding to what was sent to them. So about 67% responding to the scales, completing them before their visit through the app, secure chat back and forth, and then again, opening up the educational material, the appointment reminders, and responding back through that technology. The symptom scale, the screens, that was key for us, and especially post or during the pandemic. A lot of people, as UCLA mentioned, not coming in for those in-person office visits. This was how we got the screens out. to monitor depression, anxiety symptoms, alcohol, substance abuse in between those sessions. Not everybody had this smartphone app, of course. So we were also relying on phone calls sometimes to check in, monitor, mailing scales out. MyChart, we're also starting to build that feature out so that we can send out scales that way. But there really, overall, was just a significant decrease in symptom screening during this period of time. All right, next slide. Now just circling back to the screening workflow, this basically outlines a little bit of what I mentioned before in terms of the front desk staff administering the screens. Again, we're really trying to have MyChart. A lot of our patients are now enrolled in MyChart, or we'd like that app to be able to push out the scales because it's more widely used than the Valera app that we're using now. So we're working to transition that coming soon. And in terms of the frequency, how often we're re-administering the scale, at least annually. Some sites, if they have a solid behavioral health team on site, they will do it monthly or every 3 months, every time a patient comes in. So it really depends on the acuity, what the baseline score was, and bandwidth of resources, but at least once a year. Next. This is an example as we speak about the measurement-informed care piece, just how we triage and manage patients using the scales. And this really depends, again, if it's just a primary care physician at the site, there's no behavioral health team, they're going to respond differently. But there is a lot that they can do on their own without the behavioral health team. So not only are we looking at those baseline scores, but we're wanting to do that frequent follow-up, as we mentioned, every 1 to 3 months if somebody's scoring positive. And this graph just gives a basic breakdown of how we talk to the primary care physicians about using the screen to see how a patient's doing and what type of services they might consider providing. Somebody scoring in that 10 to 14 range, consider psychotherapy, possible referral to counseling. 15 to 19 range, we recommend psychopharm at that point. And I want to make a note here that we even created, I don't think I included it in the slide deck, but a medication algorithm for those primary care physicians not as comfortable with doing screens. You know, here are, psychopharm, some basic medication to start with, how to titrate up and monitor response. But the monitoring of response is primarily done through these screens. Next slide. Talking points, I just wanted to add this in here. There's a lot of great resources on the University of Washington Ames Center site. But what we found with administering behavioral screens on site, a lot of patients weren't used to it. Why are you asking me these questions? I don't understand. You know, what are you trying to find out? A lot of stigma, of course, around some of the types of questions being asked. So we did a training with all people involved in the primary care process and staff, anybody who interacted with the patient, from the front desk staff to a nurse, doctors, you know, everybody on the team. This was part of overall healthcare. Just like we take your blood pressure, temperature every time you come in, we're also going to be we also want to monitor how you're feeling, because that really informs the work that we're providing, the care that we're providing for you. Next slide. And then just overall takeaways. I think in terms of the technology piece, we had a lot of naysayers, myself included, even though I ran this, that this, you know, I don't know, people are not going to really respond to the app and communicating that way. It's going to seem too informal, automated. Nobody's actually going to open what we send to them. We did not find that to be the case. And there was even a lot of concern. We started using the app with more of the mild, moderate depression and anxiety patient population. When people were interested in using it for those individuals with severe mental illness, there was concern that we wouldn't get buy-in, or they might think it was too big brothery, you know, too invasive. We found that it really helped with those patient groups to actually respond to us. We couldn't get them on the phone, but we could get them to respond to the app. So I think it really allowed us to reach many more patients. Very, you know, a diverse group of patients from young to older. Obviously, it steered a little bit more towards younger, and just kept engagement going in between session. As I mentioned before, a lot of no-shows, especially post-pandemic. So we really ramped up the use of this technology during the pandemic to stay engaged with our patients. I think that is the last slide I have.
Yes, thank you so much, Dr. Blackmore. So I welcome now. We've kind of heard your both organizations' approaches and learnings, and now's the opportunity for our audience to pepper you with questions. I see one already from Dr. Lin at UCLA for you, Dr. Blackmore. So I wonder if we could maybe tackle that one first, which was, did you find the financial investment into the app was cost effective in the long run?
So we did have a special situation where we were employing the collaborative care model with the Office of Mental Health. And there was I think one slide that was showing some of the ways that you can get reimbursed for screening. We were able to get reimbursed for screening through the app, but we were also able to get a reimbursement through, it was considered care management, a clinical contact. If we sent a note out through the app and when the patient responded, we actually reviewed the material, that back and forth was considered a clinical contact. So even if we didn't see the patient, didn't get them on the phone, but just communicated through the app, we were able to consider that clinical contact for the month and bill through the collaborative care model. The reason I say it was a special circumstance is we actually reached out to OMH, asked if they would consider this, and they allowed us to do so. So I think more and more they're seeing the utility of being able to engage in this way. We also, with the video visits, have been able to bill for those as well.
Is the app free for the patient to sign up?
Yes, but you have to pay on the provider side.
Right,
so,
of course.
Yeah, of course. But for the patient, it's free. And in terms of data use, how much it uses, it's like, I think they said 10 pictures on your iPhone. I mean, it's not a lot to actually download the app. I do want to say from the financial investment standpoint as well, what we found is that our care managers and patient educators, they could manage many more patients using the app. We actually had some care managers that worked across a number of our primary care sites using the app, and that's how they would engage with patients for the behavioral health team. They keep checking in, make sure the patients were doing okay. Before the app, they were probably able to manage about 70 patients active caseload. With the app, about 130. So obviously it's going to depend on level of severity, but we did find it was just much easier to reach out, chat with patients that way, screen them, monitor, see how they were doing. I think a lot of people in general, you guys know this, like we're tied to our phones and it's easy to communicate that way. Somebody leaves a voicemail, you're like annoyed. So we found that to be the case with our patients as well.
I'd like to go back to, looks like there's another question. Thank you, Wayne. How did the screening effort, looks like this is maybe for both organizations, impact overall practice appointments, provider experience, overall collateral medical utilization, and practice revenue? So sort of a big picture lens. Dr. Jeffrey, maybe do you want to start first? Or a UCLA colleague?
I would say that, sorry, Dr. Lin, feel free to chime in. But absolutely, I would say that in terms of our appointments, this is something that we're looking at. So we, if you're interested in learning about our screening model, I guess I'll plug our paper here. We recently did a paper for the British Medical Journal, quality, BMJ quality open. And so you can, if you're interested in more details, take a look at that for the initiative that we discussed. It focuses on the pre-pandemic screening. And within that paper, we do discuss some of the rates of, in terms of not specific diagnoses, because we actually didn't pull specific diagnoses, but we do talk about some of the screening rates that we saw, and specifically talk about the different levels of symptomatology that we saw. But our next step really is to look at the diagnoses made and to really look at the care provided and those referrals. I can tell you just anecdotally, and this is without data, although hopefully that will be forthcoming for you all, that we are extremely busy in our integrated care program. And when we're rolling out behavioral health screening or depression screening in a systematic way, we saw increased referrals to our integrated behavioral health program. So I can tell you that we absolutely saw that, but again, the numbers are forthcoming. I can also tell you that during the pandemic, we've been extremely busy. Referrals for the integrated program are up, and within our Department of Psychiatry, our volume within our outpatient clinics is up 20%. So we are really busy right now. So yes, it's linked to screening, and also just, letting you know it's also linked to the pandemic, which I'm sure you guys are all aware. Dr. Lin may have more to add though.
Yeah, so our from a primary care standpoint, we are 3 years probably into sort of encouraging depression screening and the use of PHQ-9 across the board. And then about a year into this post-pandemic workflow, and really the providers are very happy with the process. When we first rolled this out, when Rachel and I sort of did our road trip, tour around UCLA of all of our primary care practices to kind of promote our workflow, the biggest complaint or the concern was always, this is going to lengthen my primary care visit. They're here for an ankle sprain. I don't have time for your depression. But unfortunately, people have depression and that needs to be addressed. So we sort of approached it as your fifth vital sign. This is a vital sign that you have to address. If someone comes in for an ankle sprain and their blood pressure is 200/100, you address it whether you have time or not. And so if it's not a suicidal patient that is not acutely high risk, you can tell them to come back in a week to talk about it. And so with that kind of mindset, our providers have actually really taken on in the primary care setting this responsibility and really had a positive experience in this whole process. And then as far as the EDUs, we were actually previously tracking that. We are preparing a second paper for our data here, but unfortunately the pandemic really dropped everything that is not COVID in the emergency room over the last year. And so that became a very unreliable measure for us, but we have to find a creative way of tracking that data, of course. And then as far as practice revenue is concerned, I think we did see an increase in reimbursement in the use of the 96127 code just from primary care alone.
Yeah. And sorry, one other thing to add to that too, I would just say that that certainly we know when we get patients into care that there is a decrease in use of ED visits for not just behavioral health related conditions, but medical conditions because of the importance of, for instance, depression on a comorbid medical condition like diabetes. We actually, and we can maybe put it in the chat as well, but in 2016 published a paper focusing on this. The paper was in Health Affairs, focused on our integrated care program, but showed a $408,000 reduction or savings related to emergency department visits for patients who were in care in our integrated behavioral health program. So I think it's really screening is a first step, right? Screening, identification, initiation of care, but we know that we get patients into care. For those patients who are in a value-based care model, we do see cost savings for those acute services.
I have one more point to bring up, and just because it's sort of all related, but something that like Dr. Jeffrey said, we've been very busy fielding sort of inquiries. And one of the things I've noticed is that there seems to be, even in a non-primary care setting, like our oncology setting, for instance, it seems like they're being staffed up with social workers, which is really great. They're also interested in screening. So it's helpful. We haven't done that yet, but it's something that we're really, we can leverage all this work done and apply to that too. So I've noticed this year we've been getting, especially from where we sit, the Division of Population Behavioral Health, we've been getting more inquiries to do more screening in these non-psych, but also non-primary care environments as well.
Thank you. One point that you made, Dr. Lin, that really resonated is the hesitancy around providers, because I think if you're a huge system or a small practice, it feels like extra work, but I think what you all just outlined, which was sort of the benefits to the patient, to the practice, and the overall system. Dr. Blackmore, is there anything you would sort of add about the system level impact that you've been witnessing?
Yeah, I mean, definitely agree with everything that UCLA just mentioned. A couple of points that I want to highlight. Yes, providers are already seeing those patients with behavioral health issues, and so we don't want to ignore it, but it's also, they go hand in hand. If you can help on the behavioral health side, the medical side, you're going to see some more treatment adherence. We did a lot of data where we found that those patients coming in and out frequently and taking a lot of the PCP bandwidth, once we were screening them and got them connected to some type of behavioral health care, they were not coming in so frequently. So we're always trying to use data like that to show how this could be helpful. We also were able to, by giving some more education and training to the PCPs on how they could use a scale like this to monitor how a patient was doing and triage accordingly, not have to manage them all themselves. They could take more ownership over those mild to moderate depression cases, do some of the prescribing, feel more comfortable with that. And we noticed with the psychiatrist that was shared across our primary care settings, her wait list time was about 4 months. Once we started doing this, empowering the PCPs a little bit more, her wait time went to about 2 weeks. So those doctors that really wanted to get their patients seen that were much more complex, we were able to open up that pathway. The other thing I wanted to mention is that with the patient educators I spoke about before, that can really help if a PCP can say, hey, let me do a warm handoff to this patient educator who can provide you more information about behavioral health. We were able to fully pay for those positions with the collaborative care model. So doing, this screening and having the PCP involved in that way. So if you can kind of invest a little bit up front and get all of that working, ultimately the primary care practice can get a little bit additional support. Oh, fine. Just a real quick final thing. Not an RCT, but some of the appointment data we looked at with the smartphone app, definitely some confounding factors here, but we did see that those patients who were utilizing the app had less no-shows and more completed appointments. It seems more anecdotally, although there is a paper out there, it's just not RCT, but those patients were more likely to just text really quick, hey, can I reschedule? Versus again, the phone tag back and forth. So there's some benefit there as well.
Thank you. So I think I'd like to use our last question to kind of close us out and have both of your teams reflect on how these approaches have been sort of taken equity into account. And I think I've heard a couple mentions of it with my chart being, limited in some capacity, but I would just love sort of some reflections on how the depression screening has been modified to be more equitable. Maybe Dr. Blackmore, you might kick us off.
Well, I think the idea of universal screening is what addresses a big part of that issue. A lot of times prior to us implementing the universal approach, doctors would, oh, this patient looks like they might be more depressed and let me screen them or let me check in with how they're doing. So what we found is it just was not being done consistently. It was not being done consistently across patient populations and patient groups. And with the universal screening, a lot of primary care docs were actually saying, I had no idea with a number of patients. So I think that is a big piece right there. We also just do a lot of, especially now, a lot more formal and informal discussion kind of trainings around equity, how it shows up, always presenting the data. Some of that was mentioned, I think, earlier with during this talk, some of the data that's out there, but keeping everybody informed of that and what can they do right then and there in terms of their practice approach and how they're managing and monitoring patients to help with that.
Thank you. Dr. Lin, did you want to go next?
Sure. So at UCLA, because you were chosen so far to use the MindChart modality for depression screening, we are definitely trying to focus. Pre-pandemic, we are also doing universal screening, but now in the pandemic era, for those that are doing video visits, we've chosen to use MindChart as the modality for that. And we, as a health system, is very cognizant of the fact that MindChart is not the perfect tool when it comes to equity. And so we have now formed a few different committees trying to improve the MindChart usage, but also just the outreach to our vulnerable population. And some of those steps have included really improving our race and ethnicity and language data. Just capturing that data is the first step into our electronic health record, and also improving. We're also loading something called the social vulnerability index score for every patient into their medical chart. And that really stemmed from our COVID vaccine and COVID screening effort, but we're also starting to utilize that in SDOH screening, social determinants of health screening, and also depression screening. And Rachel can also probably talk about our BHC in different languages.
So our behavioral health checkup, this was our tool pre-MyChart. So our tool is just a web-based tool. And I think from a tech perspective, it's easy, lightweight, easy to open up. But there's issues around HIPAA, right? So it's better to kind of go to one technology like MyChart. So that tends to work. But something that's nice with these web-based technologies is that we have some more flexibility. So one of the things that we are doing is building out a Spanish form of the assessment. So that's something very important in Los Angeles to do. And that's something should be rolled out probably within the next month or so. We were a little delayed. We were planning on doing it last year, and then we ran into some COVID. You just wanted to make sure the tool stayed alive during COVID, even though we had to go to a completely different workflow. But now that everything's stable, we can actually implement that. So increasing the languages and doing more screening, definitely agree with everything that everyone said.
Thank you so much for offering your perspectives on that, and also the work that's underway. So I want everyone to thank you. Big thank you to our speakers. On the next slide, I just wanted to say that one of the ways that maybe you could share your gratitude with our speakers is identifying something that you took away, that you learned in today's webinar, and might be able to apply at your own organization or work. We have a couple of takeaways here. That measurement of depression screening improves care, and I think we heard that wholeheartedly. That virtual and hybrid office visits can adapt with the right attention and to detail and optimization to capture depression screening, and that technology really is an effective way for engaging hard to reach patients. So please go ahead and add what the nugget that you might have observed in today's webinar in the chat, and I'm going to go ahead and close us out with a few announcements. Thank you again to our speakers. I think this was an excellent just dialogue and conversation, and would hope that you all, if you missed today, if you want to reference today's webinar, the slides will be on our CQC website. Let's go ahead and just go to the next slide. We'll do a poll in our last minute, but I understand people might have other places to be. So please go ahead and take this if you're able to. With that, we're going to go ahead and close. Thank you again to Dr. Jeffrey, Dr. Lin, Rachel, and Dr. Blackmore. Also to my colleagues at PBGH, Rachel and Valerie, and to Erica. Thank you all, and have a great rest of your afternoon. Take care.
Thank you. Bye.